we are, another podcast. Renee, what are we talking about today?
Well, you just got back from Ohio, and normally you and I connect while you're
Yeah.
gone and make one of these podcasts, but this time that just didn't work out. My work schedule, your travel schedule did not align. So we're going to do a recap of the Ohio Rural Health Conference today and talk about some of the new things you learned there and some of the things that are still the same in another state in the Midwest. So before we get to all of that, though, and kick us off, Jason, what is going on in the farm here in September?
Well, first off, I just want to say a road trip to Ohio is a great opportunity to crop scout. And so I was
Well,
able to see crops driving all the way across Illinois, Indiana. It's a very, very long trip to Southern Ohio. I'm just going to say that. But I kind of questioned how weedy some of their bean fields were as we traveled across there. And then I went and looked at my own bean field. And I realized I hadn't looked at that low bean field that's over the hill. And
oh,
even though it had just been sprayed and the thistles were dead, it didn't quite kill the broadleafs. So there's button
oh.
weeds everywhere in that field. So I was somewhat humbled because I he was trying to be a little judgy maybe about some other people's fields I saw along the highway. And maybe my own fields really don't look like they should. So
Well, me being not the farmer, but we've had a lot of extra moisture this year. So my guess, because I know what it does with my lawn, is that some of those weeds that might have been probably taken care of because of the extra moisture maybe got a free pass this year or even got a little extra boost to like kind of take over. Is that probably
yeah,
true?
the chemicals didn't really work as
Yeah.
well because there was so much moisture. Even though there was even we used some tough stuff because it was low ground, it's more food plot stuff, and so we hit it pretty hard. So it's really hard to believe that those weeds made they look kind of spindly and they got sick, but we didn't kill them. So
So before we dive in, though, you were in the town of Oxford, Ohio. Is that right? What was that
correct.
college that's there? What's college there?
University of Miami.
So what's crazy to me, and I had not had this thought in 20 years plus, but why was at one of the biggest college parties of my life at that university back in the day?
Really?
I know. And I don't remember what I was there for, really. Like I went with a school for something. Can't remember why. I remember the college I was attending, so I remember going and I remember who I was with. Can't really remember why, but I recall a big sorority party that I attended. So it cracked me up when Britt's like, I'm at this place at the wherever of Miami. And I was like, no way. And all these pictures pop back into my head of whatever I
Wow.
was doing in college at the time, but which till to this day cannot remember anything useful doing at that college. So there's that. So I was there
Well,
for something,
that
something.
makes sense because interesting when you drive around town, like it is just the university and it's
Yeah.
it's big, but that's all that's there. But when you drive around town, every house has a sign on it with the name of the house. Like
Yeah.
Netflix for life, or like they have all of these really strange, usually a
Yeah.
drinking reference of some
Yeah.
type. It's like
That
every house in the community
mm,
is like its own sorority or fraternity, like private
that aligns.
homes,
Yeah.
apartment houses, the whole street is just lined, and you have a little square
Yeah.
piece of plywood that's been
Yeah.
painted up nicely, or some of them are done professionally, of the
Mhm.
name of your home.
So the University of Miami. So yes, that would be the why. That's the only recollection I have of that trip. So I don't even know what in the world made me go in the first place. But it was just so
Wow.
funny to me. I haven't thought of that, I mean, years. And so when he came back and I said, "Where were you?" And he told me the town, I was like, "Wait, that's a weird memory." And it
You
started
could
this
have
like all these
returned.
beaches.
You had the
Oh,
opportunity to
I did
return
have the
to that.
opportunity. Maybe I should have like gone back and had relived this adventure, but I sorry I
Yeah.
missed it. So today we're going to dive into what we were talking about specifically at this Rural Health Conference, and Jason was able to attend and I wasn't. But one of the pieces we want to dive into, a couple of different ones. We're going to talk about telehealth, specifically telehospitalists. I'm interested to learn more about that. And then we're going to talk about the Big Beautiful Bill, or other names that we've now learned it's caused, and some other pieces. So Jason, kick us off here with telehealth. Talk to us about what did you learn about telehealth and how is that going to work moving forward? Like, is there changes on the horizon in this space? What are we seeing?
Well, I think it's always interesting to hear how different regions or different states are really implementing telehealth or how we're perceiving telehealth within our systems. And, I think some of the takeaways from the recent conference are really telehealth. It isn't a novelty anymore. Like telehealth is the way healthcare is delivered. And so we just have to figure out how does that integrate in all aspects of what we do. And one really cool initiative happening across Ohio is telehospitalists. So they're using these a lot in small hospitals where folks are coming in and there's an ED doctor, and the ED doctor doesn't know what the right level of care is, where the patient should go. They're just there to treat people for the emergent issue that they came to the emergency room in. And so they're using telehospitalists because these small hospitals can't have a hospitalist on staff to manage patient care while they're there. And what they're finding is they're getting people out of the ED, and they don't have to hold people in observation rooms
Hmm.
because they don't get paid for those observation bed days. They can move people to inpatient care where it can be covered because they can diagnose them correctly and then match the appropriate care with them. And I thought, isn't that a great way of thinking in the medical world about how to best use telehealth? And I followed up with the folks. It's a physician group that created this network, and they have telehospitalists all over the state. And I said,
Hmm.
how do you manage behavioral health? And he looked at me, he looked down at his shoes, and he said, we're not doing it very well yet.
Oh,
And we're not sure the path forward.
hmm.
And
That's
his
unfortunate.
first thing was, we can't find psychiatrists. And I said to him, well, I know some folks, and I could get you psychiatrists because we know telehealth groups who have psychiatrists who could
Hmm.
go into each one of those EDs and do that.
Hmm.
And so we had a really good conversation just about how the medical system is still struggling to figure out how to address mental health issues, especially in the emergency department.
Yeah. Well, it's interesting, this idea of this hospitalist. I think I was assigned one of those once when I was hospitalized a decade ago now for a bigger issue.
Yeah.
And what interestingly happened, it became in the hospital I was in, it sort of became this battle over who had the most seniority. And then they became
Yeah.
point on the case. And even if they didn't have the most knowledge about the specific issue I was dealing with, and that became a problem in my situation and becomes a problem in others. And so you don't always have a hospitalist or somebody that kind of takes point. But in my case, because it was kind of confusing and kind of challenging at the time medically, they were trying to like put all the pieces together. And there really was one person that sort of tried to loop all the different docs in. And I don't remember how many different specialists I had to encounter during that stay, but it was a lot. And so I know that is a very important piece of understanding it. And the other thing that was really helpful, a hospitalist, at least in my recommend where my involvement, they understand the language so they can interpret what each
Yep.
doctor is saying. Because when you work with doctors maybe of different specialties, they may not really understand what the other doctor is asking for or saying, or the medications get crossed or counterindicated, not on purpose. Lots of issues like that. And so it really is a key piece. So doing it telehealth, that's kind of amazing. I had never thought
Well,
about it that way.
it also bridges a workforce issue because it allows RNs in the hospital and those other practitioners, RNPs, physician assistants, to work to the top of their license because then they can
Yeah.
always consult with the telehospitalists remotely. And so you have a better chance of having a robust workforce in your small community that can manage a lot more issues in their
Yeah.
hospital because they have the ability to ask questions, to get guidance, and have the support they need.
Well, and they're not that far off from really consulting with the behavioral health side. If that piece got
Right.
connected, you'd have the
Yeah,
exact same issue because that's exactly what we talk
exactly.
about for telepsych is
Yep.
having telepsych in the ED so that that nurse, that ARNP can get the expert advice that they need and the expert
Yep.
supervision level, but not have to have that doc sitting in that ED on site and they can manage lots of places at one time. And so if those two systems connect, that could be a very powerful network for them. So exciting to see if that connection holds up for you if you were able to get them pointed in the right direction, because that'd be really cool.
Absolutely. And I think this just kind of helps us because this particular group started from a physician group, and we still have that stigma of, do we want to let the psychiatrist into our group or not? Or looking at that, is that the type of patient we want to serve? Sometimes we hear. And so thinking about how do we move to holistic healthcare, especially in our rural emergency departments, we have to link behavioral health into the loop there. And I think more and more we hear that's one of the pain points of things that have to happen. So I'm excited. I'm excited to hear how the integration across the healthcare system is going and how we can help to push forward behavioral health into that same
Mhm.
system.
That's awesome. So it also looks like we have a new acronym, Jason, that I had not heard before, and you sent it to me on a slide with lots and lots and lots of other words, and so I was just
Oh,
very confused. So what in the world are we talking about now? Tell everybody the new acronym options, I guess, and let's go from there.
well, there's a lot of options. Every conference right now is we're all talking about what's known as the big beautiful bill, and whether we call it B3 or OBBA or OBBB, everyone's calling it something different. right? However, I've not heard anyone say much of how it supports rural healthcare.
Yeah.
Everyone's talking about it, but it's really hard to find some positive parts of it when it
Mm.
comes to implementation. And so that's been kind of it's been hard to hear sometimes because it really kind of takes the air out of the room as we go through point by point. You know, a lot of the implications, especially for rural hospitals, rural
Mm.
healthcare providers, behavioral health providers, and those big questions around: are the patients that come through our door going to have Medicaid? Are they going to have Medicare? Or are we going to have a lot more unreimbursable care moving forward? And probably the reality is small communities, hospitals, and big healthcare systems alike are going to have more individuals that they have to provide care to that will have no insurance or be
Mm.
uninsured. And so I think that's kind of at the crossroads of the conversation of how do we move our healthcare system forward when it falls on those local communities to figure out, or those local organizations and hospitals.
Yeah, whenever you have a big bill like this where the goal is to save money, rural communities always get targeted because it is more expensive to have
Yep.
healthcare in rural communities. And a lot of the safety net hospitals, those critical access hospitals, those regional hospitals, all of the federal hospitals that were stacked up across the country since the 80s, since the Grassley Harkin
Mhm.
days, those aren't exactly cheap to run. And so when you look at a piece of legislation that's trying to contain costs for healthcare, those are on the top of the list. And we know, I mean, people don't want to talk about this, but I'll talk about it here in Iowa. But we've got some small hospitals that have no patients, that have no numbers of people there, but we have them because, well, our county can't go without a hospital. But you don't have anybody living there to actually sustain or use the services. And so instead of thinking like kind of like school districts have had to do with regionalizing some schools, especially small schools, as the rural population changes and moves to the more urban areas, there are less students to go to school. You can't have a school in every single small town. And so over the years, that's been changing. And you see conglomerations and groups go together. Well, hospitals have to do the same thing. But at last I knew, and last you and I chatted about this, I don't think there's a concerted effort in our state to try to mobilize to try to get people together. They were all kind of doing this one off with the different federal things that were coming down, the different offerings to try to, if I close my inpatient unit, I could become this kind of hospital and get this kind of funding, but they weren't looking at a map to actually do that in an organized way. It's not going to work. And so some of that, I mean, maybe I'm going to be the bad guy here, but some of that has to happen because how in the world are we keeping hospitals open with three people in the ED in a day? I mean, how is that even feasible financially? And so, yeah, I get that this is ugly and it's going to force some issues, but at the same time, some of that stuff people should have seen coming. I mean, just come on. So it's
Right.
like, yeah, I know it's a hard subject, but some of us in our rural states, these are real pieces. We can't just keep putting doctors in these places where there are no people to treat. That doesn't make any sense. It just doesn't. It takes me back to that conversation you had once with that small community. Was it Nebraska, maybe South Dakota, that had the three psychiatrists that specialized
Yeah.
in youth, and they didn't have enough work for them to do, but they had two or
Right.
three of them on site.
Right.
Why? Right? And they weren't going to do telehealth. Okay,
Mhm.
then what are you going to do? How are you going to pay for those people? Right? It's there's somebody has to start leading from the top and say, hey, this is what you need. And although we hate those conversations about districts and regions, that's reasons for that. You have to have enough people to sustain a system, actual
Mhm.
users of a system, and then the workforce, and then the other pieces. It stacks up. So unfortunately, you're right. It's going to be a tough road for some rural communities. So did you learn anything else about this big bill that you wanted to share
Well,
that Ohio have a take on it different than what you've heard so far?
one of the presentations was an advocacy representatives, and it was two lawyers, and so they do a lot of work for providers across the state, and so they brought up some issues with definitions that are in B3. And it was kind of interesting to hear their take on the definitions, because they kind of talked about, as we think about who's eligible for Medicaid or some of the work
Mm.
requirements that we hear about. It talks about able-bodied people, and so the
Mm.
question came up: does that mean able-bodied physically? Because there's a lot of
Mm.
individuals with disabilities or different types of mental health conditions or
Mhm.
addiction,
Mhm.
and they could be able-bodied. And so, what definition are we going to use around that? And does that exclude people who have mental health conditions? Which I
Well,
never really thought about it like that.
and heaven forbid they actually attach it to an actual definition already in the law. Just
Well,
make a
right,
new one, right? That's
right,
my other big
right,
beef. I mean, we're really good at that in our state, and I'm sure other states are too. You've got the definitions listed somewhere in your code, but if you write a new law and you don't connect it to the original definition, now you got a different definition. So then they're competing definitions. And I'm
right,
certain at the federal level, there's probably a definition of able-bodied from a lot of different perspectives
right.
and education, right? Thinking of who
Mhm.
qualifies for education, for disability services, whatever. But if you didn't connect it to one and you just took a stab at a new definition, yeah, I could see the confusion there. So also, it looks like you met somebody who's a pharmacist you wanted to mention. Maybe we'll have him in an upcoming episode. So what the pharmacist was talking about what, Jason? What are we talking about here and what might we be able to dive into on a future podcast?
Yeah, I was really fascinated. We met Jerry, he's kind of, I think we could categorize him as a recovering pharmacist. He was a pharmacist and did a lot of work and kind of really just saw all the bad things that come in the pharmacy space,
Mm.
medications doled out to milk the dollars. All of those things are kind of bad about that. And so he still is a pharmacist, but he does a lot more coaching. And so he's kind of
Oh,
taken and become, a life coach, coaches administrators of healthcare systems and hospitals. And he really did a nice job of helping us to think about how can we have those difficult conversations? How can we be candid? We always talk about having candid conversations, but how do we look towards success and how do we follow through with accountability? And so hopefully we can get Jerry on an upcoming episode. I know he's been emailing me and we were just updating our schedules so we can get a link out to him and match up some times. But he does a lot of speaking all across the country, and so I just think it would be really fun to kind of hear from him and kind of get his perspective on the healthcare system.
cool. I'm excited to meet him. He brought on some neat guests. We have the next episode is going to be a neat guest that you and I don't even know, but I'm excited to have the conversation. Looking at their background, I'm pretty excited about some of the guests we've been able to have on. So excited that we haven't had really conversation from a pharmacy perspective. So that'll be cool.
No,
So the
yeah.
one more thing you had listed here was something about an AGES model, and I know for sure I haven't heard this one before. So what is AGES? Another acronym. Love the acronyms, but AGES model. What is it, and what did you learn about it?
I don't know. I didn't know you were going to ask me about it. Did I put that in our notes that I was going
You
to talk about?
did.
I did.
You did.
That was Jerry. So Jerry talked about, I'm looking at the wrong notes, Renee. So
Oh,
how would I know what I'm
I don't
talking
even
about,
know.
right?
I'm
Um,
just following what you told me. So I thought maybe Jerry
so
talked about this, but
so he
what
did.
is
He
it?
talked about the ages model. It's attention, generation, emotion, and spacing, right? It helps us think about how we can move people forward, how we can help people from getting stuck, and how do we have those conversations. You just wanted to go into more detail than I was prepared to go into here. I was saving it for Jerry. And here
Oh, okay.
you want to preview probably
No,
what
I'm
Jerry wants to
good.
talk to us about.
But I think the
So,
general idea is it's about neuroscience and people with their memory and memory formation. So we're talking about like maybe preventing dementia, preventing
yep.
of some of the brain injuries, brain health issues that we've talked
Mhm.
about before. That's the
Yep.
general gist. And we've talked about this before. So from a pharmacy perspective, right, we've talked about this when especially older
Yep.
people who collect all their medications and have their what did my parents always call it? Their backup meds, and they just
Yep.
collected, and maybe take the wrong ones or get them mixed or all the things, right? And then you end up with psychosis. You end up with
Mhm.
just memory loss. You end up with, oh man, so many not good things. So that's a really important conversation coming up. So I am looking forward to talking to Jerry more about how all this kind of ties together. And from
So
being a pharmacist, I bet he has some pretty interesting stories.
So he can flip it between how do we motivate each other, but then how do we also coach and motivate our patients, right? And so as we think about as a pharmacist, how do you help people to stay adherent to their medication regimens? How do
Oh,
you help them to want to do that on their own, right? And so thinking about neuroscience, thinking about how we support people, how do we invite people to be in the best health they can be in by taking the steps that they need to take. And so it all comes together.
it does. It actually ties really nicely into my recovering politician self-care policy of the week. You see, I had some minor surgery a little while back, and I don't always follow the doctor's orders. I take
Mm,
them kind of as suggestions or that maybe they really don't know what they're talking about. And so in this particular case, I went two different directions. One, the doctor made it sound like it was going to be an easier procedure than what it turned out to be, on one hand. And on the other, because they just gave me Tylenol really for follow up, I thought, oh, I don't really need to take that. Well, no, I was wrong.
Uh,
And so, really fascinating to me that I'm not as good at that. And I know better, but I didn't have like clear directions. It was kind of like, oh, well, if you need it, oh, well, if so, it was all this like if and whatever. But I should have clued in when it said I couldn't lift more than
yeah.
10 pounds for 2 weeks.
Yeah.
That's a piece that should have clued in that the recovery part was going to take a little longer. But that piece seemed like an outlier because everything else was like, you might not need anything. You could probably go back to work the next day. So I got all these mixed messages. And let me just tell you, it didn't go so good because I
Yeah.
didn't clarify. And I should have asked more questions. I already know in that you guys have all heard that I've been swimming more distances. And so with the not lifting 10 pounds, I was like, well, do you think I should swim? And they're like, yeah, you probably can. And so I haven't because I wasn't dumb enough. I thought maybe I should
Yeah.
just call the doctor and clarify because I'm like, I don't think you understand. I'm not like splashing in a pool just for splashing in a pool
Right.
kind of situation. So it's just weird. So yes, I'm going to be excited to talk to Jerry because one, it's like the clear instructions from a doctor would be helpful because mine were very unclear. But then
Yep.
I don't know if I followed them correctly. But then again, it wasn't like super clear. Like the lady who left and says, "Oh, you could probably take ibuprofen," because he didn't say you can't, except if you actually read the whole big long sheet, it actually says don't because it can increase bleeding. So I'm like, you probably shouldn't have told me that, even though the notes don't match what you just said. It's wild. So all of that right there is just where a hospitalist, back to the beginning of this
Yeah.
conversation, would be helpful to get you the right information because I'm getting messages from surgery centers, which are different from the doctor's
Yep.
office, which is pieces of paper they don't match. And so I just didn't probably do that as smoothly as I could have. And it totally, part of it was me because I was like, this doesn't add up. And then part of it really wasn't. It was just bad instructions.
Yeah.
So I don't know, Jason, have you ever had to deal with that? I know you just went through this with all your mom trying
Yep.
to get her all the stuff, and I bet you not all the instructions matched, did they? And you're just like,
Absolutely not.
what are
Yeah,
we
and I
supposed
think
to be doing?
this just outlines the importance of clinical pathways and clear
Yeah,
systems and structures that guide communication and who's in charge of a case. And whether it's a physical health issue or a behavioral health issue, our systems just aren't efficient, right? Because within all of that is then inefficiency because you have too many people giving too many directions. And so we can do better as a system. And so I really think that's what we're here to talk about.
yeah. So today, everybody, we talked about the Ohio Rural Health Conference, the recap and some of our lessons learned, and we talked more about telehealth, specifically telehospitalists and how they're using it in Ohio. And that's a really neat idea that's kind of different that they're going to try to figure out how to tie into behavioral health. We're excited to see where that goes. Also talked about some of the big beautiful bill act and whether you need a bill and an act at the same time. That's fun by itself. Conversations about pharmacy and how all of this is hinged there. Can't wait to have a future conversation more about that. But before we go, please don't forget to follow us on LinkedIn, Facebook, or YouTube. If you leave us a positive review, we'll send you a prize. Have a great day, everybody. We'll see you soon.